All right, welcome to the Explainer. Today, we're going to do something a bit different, something pretty cool, actually. We're going to simulate a high-stakes oral exam for a consultant surgeon. It's called a viva. This is all about testing clinical decision-making when the pressure is on. I'll be playing both parts, the tough examiner and the candidate on the hot seat. So let's just dive right in. So here's our roadmap. We're going to follow this case right from the moment the patient hits the door, through all the critical decisions, the surgery itself, and then into post-op care. We'll wrap it all up with a final verdict. Let's get going. Okay, so picture this. You're in a silent room. All your years of training, all those long nights have led you to this very moment. Your entire career could pivot on what happens in the next 10 minutes. The examiner across the table just looks at you, clears their throat, and the clock starts now.
I am the consultant trauma surgeon on call at a level 1 trauma center. I've received a pre-alert from paramedics about an incoming gunshot wound to the neck. I'm standing by in the trauma bay with my full team ready to go.
Right. As the patient is wheeled in, my priorities are immediately guided by the ATLS, or Advanced Trauma Life Support Protocol. My two absolute non-negotiable goals are to secure his airway and to stop any life-threatening bleeding. The whole team will be working on this at the same time under my clear direction.
So those first few minutes, they are pure controlled chaos. But our approach has to be systematic. You have to tackle the biggest threats to life first, and that means sticking to the classic ABC sequence.
My primary survey kicks off immediately. For airway, I'm checking if it's open and clear. If not, my go-to is oral tracheal intubation, as long as there isn't a ton of blood in the back of his throat, making it impossible. For breathing, my team is listening for good air entry on both sides, making sure he doesn't have a tension pneumothorax. And for circulation, this is the big one here. We have to control that bleeding. This isn't the time for fancy instruments. It's about putting a gloved finger directly on the bleeding source. At the exact same time, we're getting 2 large bore IVs in, and because he's unstable, I'm activating the massive transfusion protocol right now.
Okay, an expanding hematoma combined with cervical crepitus. Those are what we call hard signs of a major underlying injury. The growing hematoma screams that there's an ongoing arterial bleed. And the crepitus, that crackly feeling under the skin, is a huge red flag that either the airway or the esophagus has been breached and air is leaking out into the tissues. The presence of even one of these hard signs is an absolute non-negotiable ticket to the operating room. In an exam, knowing this is everything. It means you skip the CT scanner, you skip any other delays. This patient's instability plus these hard signs means his next stop is surgery, period. And this right here is a fundamental crossroads in managing penetrating neck trauma. The patient's vital signs and what you see clinically send you down one of 2 very different paths. For our guy, the path is clear, but let's just quickly explore the what if.
That's a great question. If he were stable, blood pressure fine, heart rate okay, and the only issue was a history of bleeding, something we call a soft sign, my whole approach changes. The priority flips from rushing to the OR to instead doing an urgent, detailed workup to find any hidden injury.
And this really gets to the heart of it, doesn't it? It's a simple fork in the road. Hard signs mean you act, you go to the operating room. Soft signs mean you look, you investigate. Our unstable patient with a ballooning hematoma has a proven life-threatening injury. The stable patient with a little swelling might have one, and our job is to find it before it turns into a disaster. So for that stable patient, the absolute workhorse investigation is a CT angiogram, a CTA, of the neck. It gives you this incredible 3D roadmap of all the blood vessels. It's fantastic. And depending on where the bullet went, you might also add an endoscopy or a bronchoscopy to get a camera in there and look directly at the esophagus and airway. But let's get back to our guy. He's not stable, he's got hard signs. The critical take-home here is that we don't have the time for any of these scans. We've already called the OR, they're getting everything ready, and we are on our way up right now. We are now in the operating room. The patient is prepped and draped, anesthesia is good to go, the pressure is on. My surgical plan needs to be clear, but I also have to be ready to adapt based on what we find.
The location, that is absolutely key. The injury is in zone I, which is the base of the neck. This area is a real nightmare to get to surgically because all the big, important structures, the great vessels, the trachea, the esophagus, they all dive down behind the collarbones and the breastbone. A simple neck incision just won't cut it.
So, the incision is everything. I'll start with a standard cut along the front edge of the big neck muscle on the left side, the sternocleidomastoid. But then, and this is the key move, I'll extend that incision straight down and perform a median sternotomy, literally splitting the breastbone. It's often called opening the book, and it's the only way to get the wide, safe access we need to all those critical structures at the top of the chest.
Okay, so we've opened the chest, and there it is. The source of that huge hematoma is a nasty, shredded hole in the subclavian artery. Now, tackling a major vessel injury like this isn't about just slapping a stitch in it. You have to follow a very deliberate, step-by-step process to prevent massive bleeding and make sure the repair actually lasts. First, we keep control with the finger on the hole. Then, I'll carefully dissect out the artery above and below the injury so I can get vessel loops or clamps on it. That's proximal and distal control. Once it's controlled, I'll pass a little balloon catheter, a Fogarty, both ways to pull out any blood clots. Then I'll flush both ends with heparinized saline to stop new clots from forming. And finally, this is absolutely crucial with gunshot wounds. I have to trim away all the damaged, ragged edges of the artery until I'm back to healthy tissue. Only then can I start the repair. Right, a 3-centimeter gap is way too big. If I tried to pull those ends together, it would be under way too much tension, and the repair would just fall apart. So I have to bridge that gap with a graft. And the type of graft I choose depends entirely on the size of the artery I'm fixing. This is a classic exam question, right? The choice of conduit. And the rule is pretty simple. For small arteries, anything less than about 6 millimeters, you always want to use the patient's own vein, usually the saphenous vein from the leg. It just works better for small vessels. But for a big pipe like the subclavian artery, a synthetic graft made of polytetrafluoroethylene, or PTFE, is the way to go. It's strong, it's the right size, and it's ready to go on the shelf. So for this patient, I'm using a PTFE graft. This is so typical of trauma surgery. You know, bullets rarely just hit one thing. You have to be incredibly thorough and look for those associated injuries. And here we have 2 more, each one requiring a totally different plan. Okay, for the internal jugular vein, if it were a tiny little hole, I might try to repair it. But a big, complex, through-and-through injury, the safest thing to do is just ligate it, tie it off. The head has plenty of other veins for drainage, so it's very well tolerated, and it's much safer than trying a difficult repair. The esophagus, though, is a different story. You have to repair it, and you have to do it perfectly. I'll do a 2-layer closure, an inner layer with suture that dissolves, and an outer, stronger layer with suture that doesn't. And it is absolutely mandatory to put a surgical drain right next to that repair just in case it leaks. Okay, the surgery was a success. The artery is fixed, the vein is tied off, the esophagus is repaired. But we are not out of the woods yet. The post-op phase is where all sorts of complications can pop up, and we have to be ready for them. Oh, that's a classic. Milky white fluid coming from a chest tube after surgery in the lower neck, that is a chylothorax. It means we have an injury to the thoracic duct. It's a known risk of any surgery in zone Y because the duct loops right through there before it connects to the subclavian vein. That milky fluid is chyle, which is just lymphatic fluid full of fat from the diet. We probably didn't see it during the operation because the patient hadn't eaten, so the fluid would have been clear. Now that he's being fed, the fat makes it obvious. The first step is to manage it conservatively. Keep the chest tube in for drainage and change the diet. But if he keeps putting out a lot of fluid despite that, he'll have to go back to the operating room to have the thoracic duct tied off.
That's an excellent question. It's not just about what to do now, but about preventing a deadly complication weeks or months down the line. If our patient had also needed a tracheostomy for an airway injury, there is one technical mistake that you absolutely cannot make.
The single biggest pitfall is putting the tracheostomy in too high up on the trachea. If you place it at or above the second tracheal ring, it sits right in front of the massive innominate artery. Over time, the tube can literally erode through the back wall of the trachea into that artery. That causes a tracheoinnominate fistula, which is one of the most catastrophic bleeding events in all of surgery. So you always have to place the tracheostomy lower down to avoid this. All right, let's step out of the hot seat for a minute and boil this whole case down to the absolute must-know high-yield points. These are the things that, if you're taking an exam, you have to have locked down cold. So let's run through it. Hard signs, unstable patient, straight to the OR. Soft signs, stable patient, they get a CT scan. Know your exposures. Remember that for zone 1, you often need to crack the chest. Master the steps of vascular control. Always look for that +1 injury because there usually is one. And finally, know those critical pitfalls. It's safer to ligate a badly damaged jugular vein, and whatever you do,
Avoid a high tracheostomy.
And just like that, the Viva is over. You see, the key to passing wasn't just spitting out facts. It was about applying them in a calm, logical, step-by-step way under pressure, from those first 5 minutes in the ER all the way to thinking about complications 5 days later. That systematic approach is what shows you're ready.